Now let's talk about the presentation and course of of these of this atypical HUS. We often we talked about there being a prodr or a sort of inciting event, such as pregnancy or infection, because that is the first domino to drop in activating complement and disturbing this altered regulation of complement. However, we are not looking specifically for the bloody diarrhea that is more in keeping with typical HUS. Okay, so we've already talked about infection in pregnancy as being an inciting event, but of course, where that contrasts with um, the uh, the infectious diarrhea that is more typical, that precedes typical HUS. Okay, we talked about again hypertension as being common to all of the TMAs, and in this case, on kidney biopsy, there is, a predominance of arteriolar changes in the kidney biopsy. That is to say, you can see evidence of TMA within the glomerular capillary loops, but in atypical HUS, you will see more of the vasculopathy in the afferent vessels. Okay. In contrast, you might see a fair amount of thrombotic microangiopathy in the glomerular capillary tuft for things like catastrophic APS, where I'm going to see thrombi in the afferent vessels as well as the smaller uh, uh, capillaries, that is the glomerular capillaries. Again, in atypical HUS, you could sort of see a tilt towards more afferent arteriolar involvement as opposed to the glomerular capillary tuft. Because this is a disorder of complement regulation, it should be of no surprise that you can see depressed C3. Remember, alternative pathway of complement regulation does not involve consumption of C4, and so C4 is going to be normal. But when you see complement depression, which is only in about 50% of cases of atypical HUS, you may see depressed C3 or this C50, which is essentially a measure of membrane attack complex activity, so sort of a holistic view of complement activation. Okay. And you will commonly have relapsing disease in true atypical HUS. But now we have a effective therapy that is eculizumab or C5 inhibitors in general. We now have a Ultomiris. I'm forgetting the generic name for this more prolonged preparation of C5 inhibition. So we can usually control this now with effective therapy when it's available. Sometimes it's not available. This is an extremely expensive medication. Okay. And factor H is sort of the most potent abnormality or the most potent form of atypical HUS when you have a mutation or inhibitor of factor H. That may map to a more severe relapsing course. Um, and again, we've already talked about the context in which these inhibitors occur, and that can be in the setting of a systemic autoimmune process such as lupus. Lupus, once again, can be associated with both TTP and atypical HUS. In both cases, you have an inhibitor antibody that is pathogenic. In one case, you may be producing an inhibitor to the factor H. resulting in atypical HUS. In the other case, you may have an inhibitor to Adams TS13, resulting in TTP. So those are similar contexts in which that is autoimmunity and lupus, both atypical HUS and TTP can result with different push points for this inhibitor antibody to incite disease. Now, management, again, is with C5 inhibition. And we often need to treat these patients indefinitely, which is quite remarkable when you're considering the cost of this drug, which is somewhere around $500,000 for about a 6-month course of this drug. So it is really quite expensive. Now, there is some limited literature that suggests that certain individuals may be able to come off of C5 inhibitor therapy. This is weak data. It's really retrospective data from the hematology literature. It's a journal called Blood, but we don't have high level of confidence when we withdraw this therapy in patients. When that is done, you must carefully follow the patient for any evidence of disease recurrence. In patients that you're considering transplantation in, this would be one of those scenarios in which you might consider liver kidney transplantation when the problem is in a circulating complement regulatory protein that would contrast with these membrane-bound regulators like MCP, where it would make no sense to pursue liver transplantation as a cure for the underlying complement dysregulation. Okay, so again, for circulating complement dysfunction or dysfunction in circulating complement factors, liver kidney transplantation may be considered. Questions about atypical HUS before we go to TTP? Well, so the question is, how do I interpret C50? It is basically a measure of 50% activity or consumption of membrane attack complex. Another analog of this would be soluble MAC. So C50, or actually, it may even be a activity assay in which you're seeing where 50% cell lysis occurs at a certain point after you start the experiment. So again, it's a non-specific measure of complement function. Okay, and so one might assume that if I have, again, complement that consumption, you might see alterations in C50 levels. Another orderable test that you might come across is soluble MAC, where you're measuring, again, a downstream marker of overall complement activity. I don't have a lot of experience I mean, I've essentially never ordered C50 levels or soluble MACs on people. This is not a necessary part of the management of atypical HUS or even C3GN. Some people espouse ordering these tests as additional indirect evidence of these diseases, which are sometimes very challenging to diagnose. Okay, so somewhat vague answer because I don't have a lot of experience measuring C50s or soluble MACs. But again, it's not something that is high value testing in evaluating these conditions. All right, so TTP. Pathogenesis, of course, involves a problem with this protease that cleaves von Willebrand factor, this Adams TS13. And when you have a deficiency of Adams TS13, you have large multimers of von Willebrand factor, causing platelet activation as well as plugging in the microvasculature, and organ dysfunction, most notably in the kidneys. Okay, so when you look for Adams TS13 levels or activity, you're looking for pretty marked reductions in Adams TS13 activity. It's very common to see modest depression in Adams TS13 activity. I guess I've made this statement here. Most patients are going to have unequivocal severe depression in Adams TS13 in order to make a reliable diagnosis of TTP. These moderate degrees of low Adams TS13 activity are really not reliable ways to diagnose the condition. And if it's over 50%, it's essentially confidently not TTP. Okay. Now, you may have a dysfunctional enzyme or actually have low total enzyme production or an inhibitor in a underlying autoimmune milieu, okay, such as lupus. Again, often there is some form of inciting event. Infection can be one, and again, pregnancy can be another. You can see this would make the diagnosis of atypical HUS versus TTP somewhat challenging. And so sometimes you've sent the Adams TS13 activity. You cannot wait to start apheresis in the patient because you cannot exclude TTP. And you may move forward with apheresis, but then ultimately make a diagnosis of atypical HUS and reverse course and then give C5 inhibitor therapy. Okay, so again, they have similar contexts in which they can occur. And at least the pregnancy part of this should make good sense to you teleologically. In preparation for giving birth, it makes sense that Mother Nature designed human physiology such that Adams TS13 activity goes down presumably in preparation for that hemorrhagic event that's going to happen, and the need for increased platelet function, again, to defend the mother against hemorrhage during pregnancy. So again, that should hopefully explain the correlation of TTP with pregnancy, which is well described. Infection is just another situation in which you have kind of pro-coagulation or pro-thrombotic milieu, resulting in low Adams TS13 activity. Now, presentation may be informed by this plasmic score, which is used to manage patients in many cases. The plasmic score captures features of disease presentation that increase the likelihood of this being TTP. Okay, and then I give you some sensitivity and specificity for this plasmic score at a threshold of 5. Okay, so it's 100% sensitive and only about 60% specific if you use a plasmic score of 5 as a threshold for clinical decision making. Okay, and so 1 point is given for any of the following, for each of the following features. Usually, platelet counts are more severely depressed in TTP versus atypical HUS. So if I have a platelet count less than 30K, that would be a point for towards the plasmic score. If I have more preserved kidney function, right? The inverse of what I see in hemolytic uremic syndrome, where I have typically more severe renal dysfunction, then that would be a point towards the plasmic score. If I have clear evidence of hemolysis, either through the undetectable haptoglobin, an indirect bili that's elevated, or a reticulocyte count that's greater than 2.5%. That would also give you a point. Interestingly, there's a correlation between MCVs, so not having severe macrocytosis, would also be a potential uh, uh, um, um, discriminant factor for diagnosing plasma a TTP, and that's because there's some disorders of vitamin B12 that are associated with thrombotic microangiopathy. So presumably that drives this feature of the plasmic score. INR that's low, um, absence of active cancer, which would correlate with these forms of hemolytic uremic syndrome, and then absence of solid organ or stem cell transplant, which, through its association with calcineurin inhibitor use, would argue for, again, an alternate form of thrombotic microangiopathy that may be related to the calcineurin inhibitors, for instance. So you can see these are negatives that are attempting to raise the pretest probability of TTP through the plasmic score. Okay, sort of a pointing towards a differential diagnosis. Okay, the INR being low is trying to point your direction away from the DIC. Okay, so that would be an alternative diagnosis that this INR being normal or near normal would add discriminant value through. Okay, all right. So we've already made the point of this autoimmunity, which can underpin the production of this inhibitor. Relapse is a problem and is most common with very severe reductions in ADAMS TS13 activity, often because of the presence of an inhibitor. And then pregnancy-associated TTP, specifically, may happen most commonly in the second trimester, and atypical HUS seems to happen later on, that is, in the late third trimester or even postpartum. However, this general trend is not sufficient to make 100% confident decision that you're dealing with TTP versus HUS. There's significant overlap, but this is a sort of an overall trend to keep in mind as you're approaching a differential diagnosis in a pregnant patient. Management will include plasma exchange. Obviously, you use this promptly, and often it's before you get the ADAMS TS13 activity back. The plasmic score is valuable because it can help you, make those early decisions before you get your ADAMS TS13 back. I see I'm missing a letter there. And then protocols for plasma exchange might include multiple treatments until I normalize my LDH and platelets. Usually that's going to be about 1 to 2 weeks. And then if you're in a resource limited scenario, you can consider an FFP infusion, and then, as a temporizing intervention until you can get a patient over to a center that has plasma exchange that's available. Obviously, FFP would be hard to administer if the patient's already volume overloaded in the setting of acute kidney injury, but presumably this is sufficient for many patients because I'm replacing that low Adams TS13 activity through the infusion of FFP. Now, keep in mind that if I have a circulating inhibitor, that FFP infusion may be predictably less effective in turning the tide. The apheresis not only replaces more Adams TS13, but would remove an inhibitor if present. Okay, but there's been some published papers in research limited settings that FFP infusions actually is effective for treating many cases of TTP. Okay. The addition of a monoclonal antibody, which basically blocks von Willebrand factor, is now clinically available and may be considered for very severe presentations, but may not be available in all centers. But we do have it here, and I've seen it used. When there is a autoantibody that is inhibiting Adams TS13, we often are using immunosuppression to manage those patients, and that would include corticosteroids. And you don't manage these patients with platelet transfusions, even if you should have very severe thrombocytopenia, unless there is active bleeding, or there's a plan for invasive procedures. This low circulating platelet obviously is discordant from what is actually happening. There are platelets that are quite active throughout the microcirculation, and so we would not predict that somebody would, develop a spontaneous intracranial hemorrhage in the setting of severe thrombocytopenia from TTP. So again, we would reserve platelet transfusions unless, again, there's clearly active bleeding or you're planning any invasive procedure, which I would not include placing a Quinton as an invasive procedure. Do not give platelets for placing a Quinton, okay? Adjunctive therapies such as rituximab or other immunosuppressants can be considered, again, when there is a inhibitor. By the way, you can order that. It's not just Adams TS13 activity. You can assay for an inhibitor. That is a clinically orderable test. Okay. Questions before we go to scleroderma renal crisis? Okay. Pathogenesis is incompletely understood. However, we do understand that this is a situation in which you have a vicious cycle of vasoconstriction. And you, of course, know that scleroderma has a vasoconstrictive underlying pathogenesis that explains, the digital infarcts that result in this clinical phenotype. So that vasoconstriction seems to occur in the renal microvasculature as well. That results in accelerating hypertension, which may beget its own microangiopathy through sort of a malignant hypertension that causes, this nephron ischemia and hyperenanemia, and then that feeds forward to the cycle, further worsening vasoconstriction. So again, scleroderma renal crisis is characteristically, well, just like all of the TMAs, characterized by hyperenanemia, high angiotensin II levels. And so when we talk about management, in particular, we're very focused on blocking or breaking this cycle through RAS inhibition, okay? ACE inhibitor is considered standard of care. However, one can consider ARB therapy as well in this population of patients. And we would do that even in the face of worsening kidney function. So often, we withhold ACE inhibitors in people with acute kidney injury, But this would be a scenario in which you would push it even if you have to dialyze the patient for hyperkalemia. You're trying to break the cycle of a hyperenanemic vasoconstriction, and so that would be reasonable. Again, put them on the ACE inhibitor and deal with the hyperkalemia through dialytic therapy. Okay. Occasionally, we are using adjunctive therapy with vasodilators such as dry hydropyridine and calcium channel blockers. People have also used hydralazine as an adjunct. The point is we're trying to use vasodilators to try and break this cycle of vasoconstriction. And then interestingly, this is one of the scenarios in which you can have dialysis-dependent renal failure for quite some time and have a very delayed renal recovery. And so, this is scenarios. Often we're saying that if you make it to 6 to 8 weeks on dialysis, we're going to declare you ESRD because the rates of renal recovery at that point are quite low. In scleroderma renal crisis, that threshold for ESRD might be liberalized, where you can say delayed renal recovery has been well described in this form of acute kidney injury. The presentation of scleroderma renal crisis is really in the variant of diffuse scleroderma, right? You know that there's limited scleroderma and even morphia as variants of scleroderma. When you have renal involvement, it is typically in the setting of the diffuse cutaneous scleroderma. Okay, and it may occur in as many as 15% of such patients. It's usually an early part of the presentation. Risk factors include, severe disease, severe skin disease. Interestingly, there is a correlation with high-dose glucocorticoid exposure. I personally think that this is more of an indication bias and not so much a real phenomenon, though, I've seen people managed where glucocorticoids are being withheld, even though they have a pretty reasonable need to be treated with glucocorticoids because of the concern for precipitating scleroderma renal crisis. My personal view is don't withhold steroids if they're indicated in scleroderma patients because you're worried about precipitating renal crisis. I think this is more of an association as opposed to a pathogenic event. Certain autoantibodies may be also associated with a higher likelihood of this disease. And then there's a rare patient that has scleroderma renal crisis that is actually not hypertensive. So most patients have new or accelerating hypertension as part of their presentation. Okay. Questions before we finalize the TMAs? Okay, let's come to the end. Certainly the most common TMA that you're going to encounter is malignant hypertension. And the way that you discriminate this from these more complicated TMAs is you simply control the blood pressure and don't have to do anything else. And if you see platelets come up and LDHs come down with just blood pressure control, you can have confidence that this is not HUS or TTP. Okay. Now, sometimes that takes bold, moves up front to withhold these therapies. But if that's what you strongly suspect, that's how you would make the distinction. You would just control blood pressure, and if the blood pressure improves the platelets and hemolysis improve with that, then you've made the diagnosis of malignant hypertension as the TMA cause. Autoimmune diseases can also be associated with TMA. We've talked about through the production of an Adams TS13 activity and complement inhibitors, but you can also have evidence of TMA on kidney biopsy in lupus nephritis. So that's not a rare finding in lupus nephritis. Whenever I see that, I exclude concomitant antiphospholipid antibody syndrome, which of course happens in the context of lupus sometimes, though it can happen on its own as well. But if the patient doesn't have antiphospholipid antibody syndrome, I really don't, treat the patient very differently if I see evidence of TMA on a lupus nephritis biopsy. Okay. If I have, and also catastrophic APS could also be a context in which TMA occurs. Catastrophic APS can involve both large vessel and small vessel thrombotic events, arterial, venous, and microvasculature. Drug-induced causes of TMA. Old school cause was quinine, which is not something that we use much these days. Mitomycin C is certainly an old drug that's been associated with this. Tamoxifen, bleomycin. You could see gemcitabine, I would say, is one of the more common chemotherapeutics that we invoke as a cause of TMA. You can see others as well. Calcineurin inhibitors, mTOR inhibitors, VEGF inhibitors. Okay, so those are classes of drugs that you have to be aware of as causes of TMA. The tyrosine kinase inhibitors, once again, we're in the chemotherapeutics. An old first generation Plavix, ticlodipine, was also associated with it, and that's what punted it from the market in favor of Plavix. Interferon, contraceptive therapies, and then rarely these antibiotics are associated. Infections. Pneumococcal infection is mechanistically plausible and has been described as a inciting event for thrombotic microangiopathy. This pneumococcus produces a neuraminidase that essentially results in endothelial dysfunction and platelet activation as a result. Okay, and so interestingly, this is associated with a Coombs positive hemolytic anemia. Okay, so there is this expression of a red cell tissue factor that can essentially result in a Coombs positive hemolytic anemia. There is an association with other infections as well as just sepsis, generally speaking, in which we're sort of making the diagnosis of DIC most commonly. Bone marrow transplant or these conditioning regimens for bone marrow transplant, graft versus host disease, these are all associated with TMA. Uncontrolled malignancy, especially those that are involving mucin. So the thought is that this mucin overproduction activates the coagulation cascade and platelets and causes TMA. Severe humoral renal transplant rejection can cause evidence of TMA on kidney biopsy. Here's that B12 deficiency that I associated as we talked about the plasmic score. And the HELP syndrome is a form of thrombotic microangiopathy that is characterized with these other features, in the context of pregnancy. Okay?